All right, good evening, everyone, and welcome to the University of Winnipeg. I might pace on the stage because I don't often sort of feel like I'm at the theater and acting, but today I play a very limited role in introducing our featured guests and our speaker at distance. I've never done that before, so I shall do that. But again, just like to acknowledge that the University of Winnipeg campus is proudly located on Treaty 1 land in the heart of the Métis homeland here in Winnipeg. And our guest at distance, we welcome him as well, and I will get to him in a moment. Just before I get going, I just would certainly like to acknowledge our president, Annette Trimby, here. Thanks for coming out on an evening. And to Dr. Colorado and his team for putting together a very engaging set of speakers. Awful lot of effort behind the scenes. He looks composed right now with the camera, where he should be on the podium and not me. I should be taking photographs of him, and thanking him again for all his hard work. The featured guest tonight is going to obviously join us by Skype or by some electronic connection. I'll leave that to the tech folks to figure out. For the agenda for this evening, I'll give you a bit of a background on Rohit in a second. Just to give you sort of an overview of our focus for tonight, we're going to have our guest speaker. Following his discussion and a screening of a film, we have Dr. Joel Kettner here, who's going to provide a few focused comments after the discussion, probably just a few minutes to just give a reflection. And then we'd like to engage yourselves in the audience with some questions. I'll run about with a mic from side to side, and we'll try to have a bit of time to offer some questions, some thoughts and comments, and really try to wrap up by 8 o'clock. So whenever I'm asked to do bios, I try to limit it. It's not about me this evening, it's about our speaker. But I do have to admit I was intrigued by his email tagline, and it had a link to, and I quote, kick-ass Canadians. So intrigued, I clicked the button, not knowing, whereas tech people always tell you not to click the button, but I clicked the button because it seemed legitimate and very interesting. And on that site, it listed Dr. Rohit Ramchandani as a public health thought leader and instigator of global change. And when I began to read his bio, I quickly learned the impact that he has had in his short career, and one in which he's contributed to global health awareness and just the transformative impact that some of us are able to make, not only on kick-ass Canadians, but just as scholars and researchers. And I was quite impressed by his background. On top of that, by day, his home base is in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, where he teaches, researches, and provides other thought. Interestingly, too, I did, like all of us, I hit Google and I typed his name in. And the first thing that came up, interestingly, was, as an academic, I like this, was his dissertation. And almost nearly 300 pages, I actually did skim through, and it's quite impressive. But I was struck by the opening quote, to which I'll read. Globally, diarrhea remains a leading cause of avoidable morbidity and mortality in children under 5. The most pressing challenges and recommendations for the reduction of childhood diarrhea today are consistent with those described over the past decade, pointing to a need for innovation. And I think it's in that area of innovation, of thought leader, of instigator, of somebody who's committed to doing things, because when you read his bibliography and you see his adjunct status and his commitment to organizations and agencies aimed at addressing global health issues, you'll see why it was important for us to have him at distance. We'd love to have him here to give him a hug and welcome him to our campus, but I'm very pleased to present a kick-ass Canadian, a scholar, world thought leader, an instigator, and I don't know how to do this, over to you on the stage. I'm pointing to you if you can see me. And
Thank
welcome.
you very much, Dr. Kettner. I appreciate it. Can everybody hear me okay? Perfect. So good evening. Let me first of all just say what an honor and privilege it is to help kick off this Spring Institute lecture series this evening. I wish I could be there. once I heard that Edward Snowden was allowed to do his lecture via WebEx, I figured, hey, why not, right? Actually, my wife is 39 weeks pregnant, and we're expecting the arrival of our second daughter any day now, maybe during this very lecture. So if my lecture doesn't keep you on the edge of your seats, maybe that information will. I know it'll keep me on the edge of mine. So anyways, a big thanks to Carlos and the whole University of Winnipeg team that has put this series together. I know you're in store for some pretty phenomenal speakers over the next few weeks, and hopefully I can do them all justice by setting the right tone this evening. So let's get started. In his book, The Fortune at the Bottom of the Pyramid, renowned economist and professor Dr. C.K. Prahlad, ranked as one of the world's most influential business thinkers, he writes, and I quote, "If we stop thinking of the poor as victims or as a burden and start recognizing them as resilient and creative entrepreneurs and value-conscious consumers, a whole new world of opportunity will open up. 4 billion poor can be the engine of the next round of global trade and prosperity." Now, what is needed is a better approach to help the poor, an approach that involves partnering with them to innovate and achieve sustainable win-win scenarios where the poor are actively engaged. He writes about a vision of co-creation of a solution to the problem of poverty that can only be unlocked if large and small firms, governments, NGOs, universities, and the poor themselves work together with a shared agenda. And it's this mantra that captures the essence of my talk today. The university's role is but one amongst a number of critical players, and developing partnerships across multiple sectors are the ones most likely to succeed in enabling the public good. And today I'll try and demonstrate that by sharing my current work and research with you. So let me start by just giving you some context behind our work. In sub-Saharan Africa, approximately 1 in 8 children will die before their 5th birthday. In Canada, just to give you a comparison, that figure is closer to 1 in 200, a stark contrast. And the worst part is that the majority of the almost 6 million child deaths that occur each year, they're preventable. They're preventable with existing solutions, things that we already know about. Yet, coverage levels for these effective interventions are remarkably low in most developing countries. And so, where we see significant gaps are in the areas of implementation and facilitation of access. So let's take, for example, the problem of childhood diarrhea. Globally, diarrhea is the second leading cause of childhood mortality, and it accounts for 9% of all under 5 deaths. That means about 530,000 lives every year. Although there's been significant progress in reducing childhood mortality since 2000, diarrhea remains a leading cause of avoidable death in children under 5 globally. And I say avoidable because we know it works. Oral rehydration salts, or ORS, and zinc are the globally recommended treatments for diarrhea. And we know that they're effective against diarrhea morbidity and mortality in both home and community settings. But access is a problem. And recent evidence has shown that globally, of those children with diarrhea, only 1/3 receive ORS and less than 1% receive zinc. That means that on average, 99% of children that have diarrhea aren't getting the recommended treatments. Now, the recent Lancet series on childhood diarrhea and pneumonia, and Dr. Kettner actually referred to this earlier, the most pressing challenges in the reduction of childhood deaths from diarrhea include insufficient access, production, distribution, and promotion of key commodities. So there's a need to strengthen supply systems that deliver essential commodities like ORS and zinc. And these challenges are definitely representative of what we see in Zambia, a landlocked country in the south central part of sub-Saharan Africa, which is where much of my work and research has been based over the past 6 years. So, given that problem statement, our starting point was the recognition that while the shelves at rural health centers were often empty, those at community level shops always seemed to be full. And globally, one product in particular seemed to be somewhat ubiquitous. Can you guess what it is? It's Coca-Cola. No matter what country or what rural community I've worked in, I've always managed to find a bottle of Coke. Even at the last mile, somehow it gets there. Yet we have children dying in those same places because they can't get access to simple medicines. Now, there's something fundamentally wrong with that scenario. And so we ask the question, why the difference? What is it about Coca-Cola that gets it to the ends of the earth? And how can we do the same thing with essential public health commodities? What resulted was the amazing journey that my colleagues Simon and Jane Barry and I have been on over the past 6 years, what we've called Cola Life. Now, the film we'll watch a little later does a great job of taking you to the field and taking you along on the early stages of our journey, particularly that of Simon and Jane. But a lot has changed since that time. And so in a Star Wars-like fashion, what I'll do is I'll present you with the sequel before you watch the prequel and give you an overview of where we are today and what we've managed to achieve so far. So Coke reaches that last mile because of demand for the product and because of the entrepreneurial drive of small, local, private sector retailers. These are the men and women that go to a district level wholesaler. They'll purchase all kinds of fast-moving consumer goods, oil and chips and salt and sugar, including Coca-Cola, and take it back to sell for profit in their communities. And they do so via bicycle and lorry, motorcycle, ox cart, you name it. And our research found that on average, in rural Zambia anyways, these retailers visit a wholesaler at least once a week. Now this contrasts greatly with the once a month and often less medicine deliveries to rural health centers by the public sector. So adopting principles from Coca-Cola, we tried to do the same thing for these essential public health commodities. Now, at Cola Life, we're only a team of 3, yet we've managed to convene the necessary players to make our vision a reality. And so the way I've structured the rest of this presentation is to kind of give you an overview of the main components of our intervention and link them to the types of multi-sectoral partnerships we developed to make them happen. So first, we developed a partnership for product innovation. Now, one of the great things about a vibrant economy is having choice. But in a development context, one doesn't often have many choices, let alone ones that are specifically designed with and for them. But the fact is that the poor know more about their lives, I'd go so far as to say life in general, than most of us will ever know. All we have to do is take the time to listen and ask the right questions. When the poor are effectively engaged, they get more than just access to products and services. They acquire the dignity of attention and choice from the private sector that were previously only reserved for the middle class and the rich. So taking a human-centered design approach and working with our end users through a series of focus group discussions, we learned a great deal from mothers in rural Zambia. Who would have thought, right? But surprisingly enough, this kind of thing, it hasn't really been done before. And it allowed us to redefine the concept of a diarrhea treatment kit with the creation of the kit ya moyo, or kit of life in the local languages. We then worked with partners like PI Global and Amcor, renowned packaging design firms, and our local Zambian pharmaceutical partner, PharmaNova, to continually refine and improve the product. So, what did we learn by listening to caregivers? Well, we heard about the very long distances caregivers had to travel to access treatment. Before we started, the only place a mother could go to access care in rural areas was public sector health centers. This often meant traveling 3 or 4 hours by foot with a sick child on your back, or paying for transportation to get there, if it was available. We heard about long wait times at health centers, often being prescribed inappropriate treatments like antibiotics, contributing to challenges of antibiotic resistance, regular stockouts of ORS, and most caregivers having never even heard of zinc. Over and over again, we heard about the difficulties mothers had with preparing ORS, which I'll talk about in a second. The fact that children don't like the taste of the standard ORS found at the health centers. And if any of you have ever tasted products like Oralite or Gastrolite, you'll know exactly what I'm talking about. Mothers' preferences, we heard about those with regard to the branding of the kit, including image, color, and name preferences, as well as what caregivers would be willing to pay for such a product if it were more easily accessible through the private sector. So based on what we heard, and just like Coca-Cola, we made sure that the product was attractive, that it was affordable, aspirational even, that it contained high quality medicines, and that it took the science of delivery right down to the user level. So the kit co-packages ORS and zinc. It includes a small bar of hand soap, linking the messages of treatment and prevention, and making the kit also more desirable. It also contains an instructional pamphlet, which doubles as the branding for the product. The zinc is pediatric formulated, and it comes in a blister pack of 10 tablets. And the ORS comes in 4.2 gram sachets, which each make up 200 milliliters of solution. And this is as opposed to the typical 1 liter sachets found elsewhere. Now, this is really important because when it comes to caregivers actually getting ORS from health centers and taking it home to prepare it for their sick children, we found that approximately 40% of caregivers who used a 1 liter sachet prepared it incorrectly. This is because a 1 liter sachet just isn't appropriate for home use. Firstly, many mothers don't have a way of measuring out a liter of water effectively. So they end up using whatever kind of container is on hand, a mug, a beer bottle, a jerry can. I've seen jerry cans of battery acid being used. Often preparing a solution that's either too diluted or too concentrated. And when it's too concentrated, it can actually make the diarrhea worse, having the opposite intended effect and reducing the trust people have in the product and the system that provided it. So when they do prepare a liter of solution, they often end up throwing a lot of it away, or they try and save it for use over multiple days, thereby risking contamination. Now, in communities where young girls often have to travel up to an hour to fetch water that their families will use over the next 24 hours, throwing away 600 milliliters just doesn't align with their daily reality. In addition, we know from previous research that a single child will typically only consume between 200 and 400 milliliters of solution per day. So why is it that 1 liter sachets are being manufactured the world over, from UNICEF to the World Health Organization, since the 1970s? So we worked with PharmaNova to manufacture these mini sachets of ORS, and that, to our knowledge, was in Africa first. Finally, and pivotally, we facilitated behavior change through design. The kit packaging itself, it becomes a measuring device for that 200 milliliters of water. It becomes a mixing device, a drinking device, and not to mention that it was originally designed to fit in the empty spaces between crated bottles of Coke to make it easier for retailers to carry back to their communities. what the BBC dubbed the aid pod. Now, while this nesting model of fitting the kits in between the necks of crated bottles, it captured the world's imagination, and it won us a slew of awards, including the London Design Museum, Product Design of the Year Award, DuPont Packaging Innovation Award, and a recognition by the United Nations as a breakthrough innovation for maternal and child health. But it proved not to be the key innovation that we thought it would. In fact, my research showed that only between 4 and 8% of retailers actually used that piggybacking method. What they actually did was they would buy the kits in bulk in a cardboard box and put that box on the back of their bikes and take it back to their communities that way. And so, trusting in the evidence and continually focused on increasing effectiveness and efficiency, we abandoned that gem of a marketing tool, which continues to serve as a very strong metaphor for our work, but we've since improved upon the design of both the kit and its components. We've maintained the actual key product innovations, so things like measurement functionality, smaller sachets, flavored ORS, co-packaging. We've lowered the costs, and we've localized production. So it can now be manufactured 100% locally in Zambia. And that's resulted in these two new kit formats, a screw top and a flexi pack, as well as a new blister pack design for the first ever locally produced zinc, which was another unanticipated positive outcome of our work. So that's a bit about the product innovation partnership. The next partnership was developed, we developed was in order to establish an end-to-end value chain, right from the design of the kit through to manufacturing, assembly, storage and distribution, to the purchase by caregivers. With every step adding value and generating profit for the organization or the individual that was adding that value. That's the concept of a value chain. So specifically, by tapping into the same players within the Coca-Cola supply chain, we used existing networks of independent private sector wholesalers and community-level micro retailers to get the kit to the customer at the community level. Again, allowing for profits to be made each step along the way and creating that incentive to drive it. And making it affordable at the end of the value chain was essential. Now, in a value chain, value flows back from the customer as the product is pulled to the customer, as opposed to being pushed, which is the case with many public supply chain systems for medicines. The next partnership we developed was focused on social marketing and behavior change. This health promotion strategy had a number of activities and approaches associated with it, and again, with a focus on local partnerships. These included a cadre of promoters running workshops at the community level, training and paraskilling of our retailers, working in collaboration with rural health centers, posters, testimonials from mothers, radio spots, and more. All right, zebras and ostriches. It's a little bit of an awkward transition there, but zebras and ostriches maintain a symbiotic relationship in the wild. And in a way, they tend to do research for one another. You see, so zebras have a great sense of smell and hearing, but they have very poor eyesight, while the ostrich has great vision, but not so great hearing or smell. So they often partner up and travel together and warn each other when predators are nearby. So the last type of partnership I want to highlight, and probably the one most near and dear to my heart, and perhaps most relevant to the role of the university, was our partnership for research. A collaboration between Johns Hopkins University, where I did my doctorate, Antara Global Health Advisors, UNICEF, Rural Net Associates, my field team, the Ministry of Health, and others. Now, the monitoring and evaluation of this model was a key consideration right from the planning stages of the project. In fact, the operational research was a priority stream of work built into the design of the project. So we were thinking about the research components while designing the intervention, so that data generation and feedback loops were central to our work plan and an integral component of our operations. So this slide shows a simplified version of our results framework. And you can see that at the output level, we were seeking to improve availability and awareness around ORS, zinc, and the kit Yamoya more generally. We defined availability as the product being in stock on the shelves of a shop at the community level. And at the outcome level, we sought to improve access of ORS and zinc. And we defined access as the kit being in the hands of an aware caregiver. Finally, at the highest outcome level, we wanted to improve utilization of both ORS and zinc at the household level. And we know from previous research, it's very well established, that if we can increase effective utilization of these medicines, that it will result in lives being saved. Our evaluation, it used a quasi-experimental pre-test, post-test design with matched comparators. We conducted our baseline in August of 2012, our end line in August of 2013. There were 2 rural intervention districts, each with a matched comparator. We had Katete and Petaoke in Eastern Province, and Kalomo and Monze in Southern Province. The methods we used included over 600 household surveys in each district, approximately 45 retailer surveys per district, focus group discussions, as well as a series of health center impact assessments. We wanted to see what kind of an impact did introducing this kind of a product in the private sector have on the public sector health centers. So what did we achieve? I know my time is almost up here, so I'd like to just share 3 of our key findings from the trial. They kind of correspond with each of the intervention components that I talked about. So as I mentioned earlier, the 20-gram sachets of ORS that make up 1 liter of solution, they don't seem to be ideal for home use. And in terms of the product design and proper utilization, only about 60% of caregivers using those 1 liter sachets prepare ORS correctly. However, of those using the kit Yamoya with the smaller sachets and the packaging acting as a measurement vessel, 93% prepared the ORS in the correct concentration. We also found that the perception of ORS as an effective medicine for the management of diarrhea increased from 79% to 92% of caregivers. Now, this is also actually really important because when we look at, if you take the Sustainable Development Goals, the SDGs as an example, the global indicator of success for diarrhea is coverage. So when we're seeing coverage rates of 60%, and we're very happy about those kinds of coverage rates, the reality is that effective coverage is different from ineffective coverage. And so the utilization piece and proper use becomes very important. Next, with reference to the value chain as a whole, at our baseline in 2012, less than 1% of children with diarrhea were given the globally recommended combination therapy of ORS and zinc. However, by end line, of those children with diarrhea in the 2 weeks preceding our surveys, 45% used both ORS and zinc. And in the comparison districts, utilization of ORS and zinc remained at less than 1%. So a big effect size there. Finally, our baseline showed that on average, caregivers across our intervention districts were traveling over 7 kilometers to access ORS at the health centers, and rarely were they getting zinc. At endline, caregivers using the kit Yamoya only traveled an average of about 2 kilometers to access these medicines at their local shop. So where are we today? It's been about 4 years since the the end of our study, and as well as the trial. And given the results, in collaboration with the Ministry of Health, we're now in the process of scaling this model up nationally with support from the Department of International Development in the UK, the Scaling Up Nutrition Program, as well as from Save the Children and GlaxoSmithKline after winning their 2014 Healthcare Innovation Award. The scale up work, it's taking place under what we've called Kityamoyo Transition to Scale, or the KITS project. This project has basically three components. One focuses on urban market development in Lusaka. Another focuses on the 14 most underserved districts, called KITS ACE, Adapting to Challenging Environments. And the last focusing on a formal public-private partnership with ShopRite, which is the largest grocery chain in sub-Saharan Africa. And through these methods, we're scaling it up nationally quite effectively. And a key win within the KITS ACE piece, and it's been really a boon to our scale-up process, has actually been the order of 452,000 kits by the Ministry of Health for free distribution through the public sector. And that's in some of the most hard-to-reach districts in Zambia. These kits are branded not as Kityamoyo, but as GRZ products, Government of the Republic of Zambia. And it's the exact same product as Kityamoyo, it's just branded differently. It maintains all the same design features. And this will be the first ever public sector co-packaged diarrhea treatment kit in Zambia, making it one of the few countries in Africa to actually offer a co-packaged product in the public sector. This will actually serve as a benefit to our private sector partner, PharmaNova, as well, as it provides an anchor client and helps kind of secure production and provides the buffer for them to continue manufacturing for the private sector. Also, in the private sector throughout Zambia today, one can find the Kityamoyo logo painted on the outside of shops right beside the Coca-Cola logo. And so that picture sums up quite a lot for us, and so we're really proud of that. So just to wrap it up here, I thought I would leave you with some key points for consideration and reflection and discussion. So the first is the need to recognize the gaps in our knowledge, in our skills, and in our expertise, and to develop the right partnerships to fill those gaps. You have to surround yourself with the right team. And with Cola Life, one of our major achievements was the establishment of this multi-sectoral partnership. And these kinds of partnerships are energizing and transforming the international health landscape. And we've developed this series of what we call unlikely alliances to make our model a reality. And closely linked to this is the concept of integrated innovation. What Grand Challenges Canada defines as the coordinated application of scientific, technological, social, and business innovation to develop solutions to complex challenges. Now, this approach highlights the powerful synergies that can be realized by aligning these different forms of innovation. And it recognizes that scientific and technological innovations have a much greater chance of going to scale and achieving sustainable impact if they're developed from the outset with appropriate social and business considerations. It's this kind of multi-pronged approach that can be facilitated by working across sectors. My second point of reflection is to really highlight the importance of one of those sectors or partners, and that is academia, universities. We have a critical role to play in achieving the public good. There's no question about that. And in today's world where it's even possible for the concept of alternative facts to exist, our role is more important now than ever before. How to apply the scientific method, how to test different theories, how to effectively measure and assess outcomes and impacts, use evidence to innovate, distinguish between good and poor quality information, share and debate knowledge with a diverse range of audiences, educate, and train the next generation of experts. These are crucial functions, an area where universities can add tremendous clout, but we must also be present enough to realize these are just pieces of a much larger puzzle. The big challenge for humanity is to get everybody, not just the elite, to participate in globalization and development and avail their benefits. And this applies to universities as well. Make no mistake, there is such thing as an academic elite. We publish papers for other academics and those that speak the language of research. Our central currency. When we choose to publish in journals that aren't open access, we limit our reach and our ability to influence change. The costs of higher education these days make it inaccessible for large segments of the population. I can assure you that most of the mothers and children I work with around the world will never read any of my papers, and neither will most of the frontline staff implementing our work on the ground. But the fact remains, taking risks, results and impacts, sound methodology, representative samples and reduction of bias, the truth, these have an essential role to play in the process of achieving public good. Now, as a university, as a doctoral candidate at Hopkins or a professor at the University of Waterloo, I couldn't have achieved any of this alone or within the confines of the university establishment. Neither would the government of Zambia have been able to achieve this on their own, or the pharmaceutical company on their own, or Zambian caregivers on theirs. We had to break down silos and coordinate partnerships to make this happen, bringing the best of each sector to the table, and do so in as transparent of a way as possible. And that's why we shared everything online through our website and ongoing blog. Our research, our lessons, our challenges, our processes, our wins and our losses. And this open, collaborative, multidisciplinary, bottom of the pyramid up approach was crucial to our success. The third point for reflection is the idea that by adopting a systems lens to assess bottlenecks, we can identify the types of partnerships, sectors, and players necessary to address social challenges. Now, in this case, we applied a health systems lens, and that's all this image is really showing, is an access to medicines framework from the perspective of the various components of a health system. So things like leadership and governance, resources, including essential products and health staff, market forces, financing, transparency, service delivery to the community level. And by identifying the challenges in the system, based on what we heard from caregivers, we were able to engage the necessary players involved at each of those intersections and really develop a holistic approach to the problem, addressing issues of both supply and demand. And perhaps the most important partnership we developed in that process was this bottom gray section, individuals, households, and communities. And that's where my final point of reflection comes in. And to share that point with you, I wanted to share a video from one of my field visits with you, but unfortunately WebEx doesn't allow for that. So I'll just, I'll try and paint you a picture. We had just pulled our truck up to one of the village retail shops that we were working with. And a group of kids that were playing nearby, they came running over to the side of the truck. And for what seemed like the first time ever, they saw their own reflections in the side of the truck. And the reason I wanted to share this video with you was because for me, it emphasizes a very important point. And that is that context is key. The fact is that we can sometimes take something as simple as a reflection for granted. But that's not to say that we should ever stop reflecting. As change makers, global health or otherwise, we need to remember who we're working for. It's not our companies, it's not our universities, it's not ourselves, it's our end users, our patients, their caregivers, the communities where we're trying to make a difference. And understanding those end users, yes, their needs, but more importantly, their desires, their preferences, their aspirations, their demands, their realities is paramount to delivering effective products and services and achieving the public good. So with that, I will zip it. Thank you all so much for allowing me to share our story with you. I'd just like to acknowledge our donors, and I hope you enjoy the film, after which I believe we will be having a moderated Q&A discussion. But before I let you go, I just want to give you a brief background on the artist behind the Cola Road, Miss Claire Ward. Aside from having become a great friend, Claire is an award-winning Canadian journalist and documentary filmmaker. She's based in New York City. The Cola Road was her directorial debut and has screened at global health conferences, universities, and film festivals in the US, UK, Canada, Malaysia, Zambia. It should be noted that it's an independently made film from her perspective, while following my partners Simon and Jane at the very start of the project during the test run of our model, while I was busy collecting our baseline data. And recently, Claire's short documentary, Free Advice Girl, it's called. It premiered at Hot Docs Film Festival in Toronto and was a finalist in the International Documentary Challenge. Claire now shoots and produces news documentaries around the world for Vice News, and is a contributing writer to Maclean's magazine. She's also very actively engaged in academic discussion of professional ethics in journalism. So with that, please enjoy the film, and I'll see you right after. Thanks.
Today, more than half the world's population live in urban areas. But in many developing countries, a majority of people still live in remote rural environments. Zambia is a landlocked nation in southern Africa, and most of its 14 million people live great distances from the major cities and towns. Zambia is the home of Victoria Falls, Africa's top football team, and one of the world's fastest growing populations. It is also a country where 1 in 7 children die before their 5th birthday, from preventable causes like dehydration caused by diarrhea.
Diarrhea is still a leading killer disease in children under 5. This is really a huge problem.
For many mothers, taking a sick child to get help can mean walking all day. Rural health centers are understaffed and constantly face shortages of basic medicines like oral rehydration salts. ORS are essential in treating dehydration. The Ministry of Health struggles to meet demand. It regularly transports medicine to the major district towns, but getting that last mile into rural villages is a huge challenge. Bad roads and strained resources mean people must wait.
There are shortages. Like now, we only have 1 box of ORS.
This is the ORS that we have, but we don't have zinc sulfate at the moment.
Since most cases are diarrhea cases, I think it will be finished by a week.
And then what happens?
We do give them health education by using sugar and salt to make homemade ORS.
Do most mothers have sugar and salt?
No, some of them can't afford to buy.
next to these struggling health centres, rural shops are stocked with goods. One product in particular seems to be just about everywhere.
You will find Coca-Cola in any village at any time in the course of the year, but you will not find medicines. What's the difference? There is something there to learn from.
This is a story about thinking outside the box and inside the crate.
We are doing just about 1 million cases a month on average, which is about 75, 80,000 hectoliters. If you tell somebody here, buy a drink, you haven't mentioned what drink to buy, but the first thing that will come to their mind is a Coca-Cola. It's still the #1 seller, I think, all across the country.
I was travelling a lot in Chinzali district because we were involved in a development project, and it struck me how you could get a Coca-Cola, it seemed, in most places, and yet there was this background of 1 in 5 children not reaching their 5th birthday.
And we had 3 children under 5 ourselves, so, you know, who got ill and so on and so forth. And so it was very, you know, clear to us that, you know, you needed to have access to simple medicines and know how to use them and so on.
Yeah. So the very initial thought was, if we can get Coca-Cola out to these places and get the bottles back and the crates back and people know what to do with it and all, you know, why can't we do the same thing with a simple public health product?
20 years later, Simon decided to share his idea.
That was what got the BBC interested. Through the BBC we got to Coca-Cola. Coca-Cola then could see that you know, the support, the support was growing.
We started with this idea that Coca-Cola gets everywhere, medicines don't. Why don't we piggyback, quite literally, physically piggyback on the Coca-Cola system? And we came up with a pack which fits between the necks of the bottles in a Coca-Cola crate.
We're going to be ironing.
We're going to be ironing the samples.
The prototype's innovative design got a lot of attention in the public health community. The blatant reference to Coke, however, raised some eyebrows.
We're not promoting Coca-Cola, we are piggybacking on their successes and hopefully diverting some of that expertise into the public good.
They have achieved things and can do things that the public sector hasn't achieved. So are we going to carry on in our silos saying bad, good, and actually, if we adopted some of their principles, we'd be better?
What our government has done is to make clear that we accept the role of the private sector and the collaboration between public and private. There was a period of suspicion between the two, and any thought that these money-seeking characters could actually do good was not acceptable at that time. And as we have grown over the generations, we have begun to accept capitalism as having potential benign effects as well.
One of Cola Life's early fans was Rohit Ramchandani, a Canadian working toward his doctorate in public health. He felt Cola Life needed a strong foundation in research and proposed to help set up a trial. So he emailed Simon with this pitch.
Harry Truman once said that actions are the seed of fate. I hope you will consider this email to be one of those seeds. It's a little bit nerdy, but...
I've been in the field over the last 2-3 weeks, and I've started kind of looking at the numbers that we've been collecting in our baseline, and the numbers are staggering in terms of the prevalence of diarrhea. You know, we ask the question, do you have a child that's had diarrhea in the last 2 weeks? And we're seeing numbers in like the 50% range. And so how do we demonstrate most effectively what kind of an impact this program will have and how this model will work and how this model can work to save lives, essentially. And that's really what we're here for.
With Rohit on board, the Cola Life team grew to 3.
Good to see you.
Together, they raised enough funds to support a trial in Zambia.
We wanted to put in what WHO/UNICEF recommend in a diarrhea treatment kit, which is zinc and ORS.
So there's a small bar of hand soap that fits right at the top.
Soap is going to actually avoid 40% of diarrhea cases.
It sits on a tray, which can be removed. That tray also serves as a lid for the container.
What is key about Zambia and about these particular components is that it doesn't have to be a pharmacy or a drugstore that sells them. And for Zambia, that's absolutely vital because there are so few retail pharmacies in this country.
They call it Kit ya Moyo, which means kit of life. Through selling the kits instead of giving them away, Cola Life hopes to build a market for basic health products.
We're interested in the last mile. And the interesting thing about a Coca-Cola crate is that Coca-Cola crate goes the last mile in a rural area, on a bicycle, on an ox cart, on a donkey cart, on the back of a lorry, in a bus, or however it's transported, by a completely independent local entrepreneur who brings it there because he or she can make money from that particular commodity.
The idea has captured the world's attention.
We need to revolutionize the way that we do global health.
In the summer of 2012, Cola Life was 5 weeks away from the launch of their trial, but there was still lots to do.
What we're doing is we're trying to, it's like...
Okay, perfect. So sorry,
Kit Yamoyo.
Yamoyo.
In the next couple of weeks, we are going to be running a test run of the whole system.
The test run is going to take place going from Kolomo to this little village here, Siachitema.
So these guys come in here
Yes.
and go there to get their supplies rather than struggle all the way across here.
Simon doesn't plan to go it alone.
I'm white, I'm 6'2", I've got weird hair. When a person like me pitches up in a local community, people behave differently, and that's not a good thing. So I really do try and keep a back seat as much as I possibly can.
I've got so much travelling for you and Simon. You know, I don't know whenever you're going to be at home to see your new baby, because I've got, you know, maybe Monday, Tuesday in here in Lusaka, and then Wednesday, Thursday, Friday here to Katete, here to Kolomo, back to Lusaka, back to Kolomo, back.
Jen, you don't need to worry about that.
He will grow up, he'll say, "Where's my father? I've never met him."
Albert he's trained as a social worker. He and I travel around a lot. And he is totally brilliant in the frontline situation.
What's the story, my boy? I'm a nobody without my family. You understand? I'm not the complete person without my family. In our country, there are so many challenges. One of the things that bothers me a lot is to see children die, especially those in rural areas, in the remotest rural part of Zambia, who, if they survive, they can be future leaders.
conversation we had about driving, I hate being driven. There we go. That didn't happen very long ago.
No. African chicory. They cover long distances. When you want to implement activities in any district or in any community, there are certain structures that you cannot overlook, that you cannot ignore if you want your programs to be supported and also you want them to be sustainable. Oh, so mwanyama wa useninga musigaji ndinzo.
Amendo.
And then would you have a doctor normally at a health centre like this?
No, not a doctor.
No.
I'm a clinical officer. Clinical officer.
Oh, okay. So that post remains vacant?
Yes.
I was interested on your end wall there, you have the Millennium Development Goals. And I think it's number 4, which is about reducing child mortality. We were sort of inspired by the Millennium Development Goals, but also quite shocked that so many so many children died of such a simple cause, which is dehydration. And also we noticed that in many places, in many medical institutions, either they're a long way away from where people live, or they don't necessarily have the stock of the medicine that people need. So what we were trying to do, in collaboration with the Ministry of Health, is we're trying to get kits like this into shops. Okay. Not just the shops close to health centres, but shops further in, more remote shops, which may be a long way from here. So instead of someone having to walk a long way to a clinic, they can treat diarrhea in their home. They can buy this and treat it now. What do you think of that?
It's a very good idea. It's a good idea. And I think it's going to be very helpful to a lot of people that are very far away from clinics, from health centers.
Yeah.
In one part of the country, this international NGO went to this community, assessed the situation, and thought, oh, mothers here suffer, women here suffer, because they cover long distances to go to the river to get water. I said, how do we help these mothers? Let's sink a borehole 500 meters away from their village. They called the community and said, we've seen all your troubles. We've understood all the problems that you women have been going through. And to address those problems, we've constructed this water point and we are handing it over to you. Time passed. They came back to see whether the lives of the mothers had improved. And they were seeing mothers bypassing the water point, going back to the river. And so they were bothered. They called the mothers and said, we've observed with sadness that even after having done all these things, we seem not to have helped you people. Why are you still getting back to the old way of doing things? So they said, if you had consulted us mothers, we would have told you to sink this borehole near the river. So people were surprised, but why? The reason is very simple. This water point is near to our villages. So because it's near, we only walk shorter distances, and we cannot discuss our husbands, we cannot discuss things that are affecting our families. So we'd prefer go to the river because that will give us enough time to discuss our husbands, to discuss our families, to discuss different family issues. The problem is that you never consulted us.
We're doing a series of 6 focus groups in every district, and these are qualitative interviews, so they basically will just supplement the key quantitative surveys that we're doing, and it just makes the analysis a lot more rich, and the information you get from these things is just fascinating and invaluable.
After 5 minutes, kuti wanga uchinyoka kuti wachiswa kusomwa na mwana kachiyandi kunyoka mwana nkoro omwani na yasimba waiwatu okunguru asigatereka kambata chiyandi ndiza wala kwa kuseni elionso waito kupera kaka akoro zikasaka
kuti booking wanga chitatira
makatayo hinje mubanga yo mwana aba akusoma je mubanje mwana aba
Partnering with the shops, and then the shops will make them available to the community.
Kusiga matena waziyamana kupanga kama.
Okay. Ndio mberesi wangu mbo ndiko therapy.
Ino muri Jesu mwana ujeswa unganda.
Kwadi.
Sumenda bo mai. Menda bo ORS. Ino ngamujana uri.
Which is better, you know, happen to me some shorter guy.
So this guy wants to buy this.
Yeah.
He's got 5,000 kwacha.
Yes.
His son has got diarrhea. So why aren't we giving it to him?
Baseline.
You're ruthless. You're ruthless.
No, I don't.
Rohit. I think we should sell it to him.
Claire, I've sold, huh? I have more money in my pocket.
So that is the first time one of those has been sold.
Yeah. So
Yes, this is the very note that was used to buy the first Kityamoya. So that's going to go in a frame with an explanatory note underneath, and it's going in the Code Life office. So that's a very special 5,000 kwacha note.
This is the last mile.
Right, you know it's empty.
Yeah, definitely.
Is that for dinner?
Yeah.
Is that for your dinner?
Yeah.
Enjoy, bon appetit.
Even with the successful sale of the first kit, the difficulty of transportation sinks in.
Oh, it was almost going to be bent this way.
Yeah, it was.
It's so hard to tell on these roads, right?
I don't like that person being underneath the vehicle.
Oh, that one.
Don't go under the vehicle.
Don't go into the vehicle. Come out from there, because if it comes down...
Oh, but this is where someone Jack is.
Okay, hang on. Let's just have a look.
I'm asking for the loose one.
Oh, yeah. Well, I'm a bit annoyed that I didn't notice it earlier, but then it's very difficult on these corrugated roads. Anyway, most important thing...
All's well that ends well.
This is the material that it will be, and it will be completely waterproof. And then these are going to be arriving in cartons to you. And in each carton there'll be 7 bags, and each bag will have 5 of these in.
So 35.
35 in a carton. This is, I mean, again, if we get to the stage where this rolls out, which we hope it will, this is the sort of poster you'd have.
Like I always believe in, a lot of work is done in offices and people don't understand what's on the ground. So the success of this will be measured by what we do on the ground here. You can make the most powerful leaflet ever. You can make the most powerful poster ever. But if you don't know how to talk to the person on the receiving end, then maybe that poster, that leaflet might not work. So it's us guys on the ground who are having first-hand experience with the recipients, and what we do and what we say is what will matter.
We were trying to assess if at all would be interested to be selling the kit, and from our discussion it looks like he's quite interested. From what he's telling us is that people are able to buy, and there's demand for such drugs. He mentioned that you can sell the kit at 5,000 kwacha, which is what we are proposing, and that is great.
Yeah. Okay.
Okay, shall I do it from the outside? So we told to put delivery. Normally, these boxes, when we get started properly, just one.
When you'll be grown up, fully grown up, right? Yeah, and you have grandchildren, you should be telling them that I was the first one to
sell the kit in the whole.
I was the first one to order the kit
Kalomo.
and sell it. The whole Kalomo, the whole Zambia, and the whole Africa.
Oh, good.
And the whole world.
Oh.
Die-hard person, eh? I can look at, this dream, the Kityamuya thing.
Yeah, persistence.
It was in his mind for more than 20 years.
Yeah, that's right. That is true.
And it's something that he wanted to have it as a dream come true. And here we have it. So
people just gotta buy it now.
Yeah.
I did some calculations the other day, and there has been progress since the Millennium Development Goals. The rate of improvement in child survival had increased at 2% per year. There's been some progress, and that's great. There's a lot of people who work really hard to get that progress. However, at that rate, it will take 175 years for child mortality in developing countries to reach the levels that they already are in the US and Europe. Now, if you're happy to sit around for 175 years while the existing process improvement carries on, that's fine. What we want to do is try something out that potentially could provide a step change. So not 2% per year, 10% per year.
You should make an effort since you have managed about this medicine, also malaria.
Malaria, yes.
Malaria, and even not only that, even other medicine. It will be advantage for us instead of going to town. They should buy here.
You made it.
Jane,
How are you?
you missed Simon.
Of course I did. I missed you. I missed you, Albert, also.
No, I brought him back.
I can always rely on you.
Cola Life needs to mass produce the kits for the trial. The local pharmaceutical company they've partnered with will be manufacturing the ORS packets as well as assembling the kits, but they don't have the right machinery to seal them properly. So Simon and Jane have ordered a specialized sealing machine from the UK.
This is our baby. We've been waiting for it. This is the sealing machine.
Totally functional.
I can't believe it actually got here today.
We're going to Farman over on Monday.
Yeah.
Anyway.
So you're going to install it, and it's just in time. So we've got to make, well, not us, but Pharmanova, our pharmacy production partner, has got to make 41,000 of these Kitiomoyo. And if the demand goes like we think it's going to do, we may even need to make, thousands more. Who knows?
Yeah, so
And then, the key is when are you around to help them set it up? So I've now changed activity 1.
Setting up involves plugging it in and switching it on.
And showing them how to use it.
Yeah.
Yeah, I know, but there are some little bits and pieces that they would like to see, I'm sure.
Off you go. Watch for this green light. Right there. Just quite a force.
Even as production ramps up, Cola Life is questioning how much this project will really rely on Coca-Cola crates at all.
So physically piggybacking on the Coca-Cola system may not be the innovation. We think now that piggybacking on the Coca-Cola model is the innovation. And what they do is they don't do that last mile. They don't get it into those really remote places themselves. What they do is they create a brand, they create a desire, a demand for their product, and they make it profitable to fulfill that demand.
Oh, Pedizinc is for strengthening. Okay. Preventing infection and using soap. It's affordable. I think women around this place, as they are interested in gardening, they will be able to be buying these kits for their children, for their babies.
Across the bridge, there is no more sorrow. Across the bridge, there is no more pain. The sun will rise across the river, and you'll never be unhappy again.
Wakuta? Nona. Nona. So. Chata.
Beti ushakumacha ati ulendo wapya tieni kundola vovala talonga tuchola taimya tayambapo ambuya tenze tonse munjila tenze tonse kunganda ambuya mwenilanga njila za kwino lomba nazionela aye manawe kumbuka ulanda wanyoko chalo chino chilina meno ulesi ni musamilo obaba siku ya lula wanzi wa muntoni pachinso.
It's pretty hard to follow a film and a speaker like we've just been able to absorb. Wonderful music, a wonderful story from changing tires to changing lives in the world. I know we're going to have lots of questions for our special guest, but just before that, we're going to give our own special guest here, Dr. Joel Kettner, an opportunity to just reflect, provide a bit of context, and then we'll move right into Q&A. And I think I'm going to get some fitness and move a mic around for some Q&As before we close the evening. So, Dr. Kettner.
Good evening, everybody. Now, can our speaker, is he still with us? Oh, good. Hello. We haven't met before, but this is how it's going to happen. I don't know if you can see me. I can see you on the screen. So I'll just spend a few minutes, well, actually, hopefully just a moment, telling everyone who I am and why I'm here, or at least why I think I'm here. My name's Joel Kettner, and I'm a public health physician. I've worked most of my life in Manitoba. I've been a provincial public health physician. Now, most of my time is spent teaching, mostly at the Medical College at the University of Manitoba. I'm an adjunct professor here at the University of Winnipeg in the Department of Indigenous Studies, where I was involved initially with the Masters in Development Practice program, which carries on here, of course, at the UW. I'm also with the International Center for Infectious Diseases, which is a not-for-profit knowledge translation organization, which is actually located at the Richardson Science Building here at the University of Winnipeg. And most of our work is developing partnerships between industry, government, academic centers, and community-based organizations to reduce the burden of infectious diseases. So for me, this is a pretty exciting topic to be dealing with, and I'm honored and pleased to have been asked to be a discussant. So now the problem is, what is a discussant, and what is a discussant in a university environment? I've had lots of opportunity to discuss things in the media, in front of ministers and public health bureaucrats, and of course many other venues. But when I'm in the university, I think of a discussant as someone who has a role of stirring things up a little bit. And that's sometimes very hard to do, especially after a presentation like this and both our speaker and the film. And I sit there because it's my job in the university environment to think up what some people call counterfactuals, not alternative facts, this is different, counterfactuals, or at least counter questions, so that sometimes things which appear almost too good to be true, we need to ask questions about how good and how true. And so I'm going to be a little bit of that kind of stimulant for you, Dr. Ramchandani, because as an academic yourself, I'm sure this is exactly what you would want me to do. and to make this interesting and important for you to be able to reflect on some questions which I'm sure you have been asked many times, and I look forward to what I'm sure are going to be very satisfactory and more deeply enriching answers to the questions. So how much time have I got? Can I take 5 more minutes? 5 minutes, that's all I want, maybe less. Well, the first thing is context, this problem, which is a huge problem, and I won't spend any more time talking about it because it's been beautifully laid out as such an important problem in public health in a global context. We have problems like this here in Manitoba. They're not quite the same, but when you go up to a northern remote indigenous community where you see poverty immediately, and you go into one of the stores there, you see Coca-Cola and potato chips lining the aisles, and sometimes it's not as easy to find fresh fruit or produce, or milk, or unsweetened juices. So I won't say more about it, except that we shouldn't imagine that this is entirely on the other side of the earth kind of a problem. And there's probably some lessons in this discussion for us here as well as in Africa. There were, I think, 5 moments in the film that I want to relate to that I think really capture my main thoughts and questions. And some of these are not the ones you might think of, because the more important and obvious ones I'm not going to repeat. The first one that I want to relate is the question to the health worker in the clinic, which was, what are you going to do when you run out of ORS? And she said, we're going to educate women to use sugar and salt to mix it with water, which is actually, well, I don't think she said this, but I can tell you, is quite effective for most diarrhea cases that can be reversed with oral rehydration. The more amazing next sentence was, to me, was that they don't have sugar and salt in the home, or that's what she said. So that's, that was the second thing. I was struck by the conversation about consultation, the well story and the river story, and I have a question about the degree of consultation that has taken place about this approach, which ties in with first observation, is why not sugar and salt in the home on an everyday basis that might actually be cheaper than the $1 US package? Is that what it was? I don't know how much that is, but I imagine that's not that cheap. So that's a question that I would be interested to know what the consultation would have resulted there. I thought that the description which came at the end of it about what is really the model of Coca-Cola that's being used here isn't necessarily so much the carton to put the products in, but the model that Coca-Cola used, which was to create a demand and then fill it. And I was struck by that. And then the other point in the film was the comment, it's all's well that ends well. And from a public health perspective, that really is important. The process of how we get there is also important. And the broad implications for bigger questions and bigger pictures are important. So I couldn't help raising questions about why is there so much infantile and child diarrhea? Is it the soap, absence of soap? Well, that might be a part of it. Is it malnutrition? Yeah, I know that's part of it. Is it zinc deficiency? Yeah, I know that's part of it. Is it poor quality water? Yeah, I know that's part of it. Is it food quality? Yeah, I know that's part of it. Is it child rearing and child development? Yeah, I know that's part of it. A lot of that does have to do with poverty. And so as a public health thinker, getting at root causes and thinking from a population perspective and a prevention perspective, I think there's some questions I'd like to bring into the conversation about this piece of a bigger puzzle, which I think, Rohit, you used that very important expression. where does it fit in the long run that all will end well, in view of some of the other things that maybe I don't have time to raise right now, and I'm hoping maybe some of you have thought of and will ask questions. So with all due respect, I'm very thrilled about this work. I think a lot is going to be learned from it. I'm glad it's being researched, and I'm glad it's being researched by academics who are disinterested, objective, and are committed to examining things from all sides, and looking for the counterfactuals at all times, because that's what academics do, and that's what university discussions need to be about. So I'll stop there, and I think I'm probably done. I'm going to let you, Jino, moderate, I think, the discussion, and I will go back to my place in the audience, and I'll look forward to the conversation.
Well, thanks, Joel. So, Rohit, I don't know if you have some comments to some of Joel's thoughts there, or...
Sure. No, I can address a couple of those. Can everybody hear me okay? Can everybody hear me okay?
Yeah, go ahead.
Okay, perfect. So a couple of points there. So the sugar salt solution versus ORS debate is one that comes up quite often. And we know, for years, sugar salt solution was promoted as using easy to make, ingredients that are available at the household level. But since that time of promoting sugar salt solution, which was a big area in the 1980s, we've done further studies to really understand the differences and the challenges associated with sugar salt solution. And as our research has shown, with ORS, when you're getting a packaged product that is to be mixed with 1 liter of solution, 40% of the time it's being mixed incorrectly. And so you can imagine that with something like sugar salt solution, we get the same kinds of challenges. And often those solutions are haphazardly prepared. And mothers often don't remember the right formulation of 1 teaspoon of salt to 6 teaspoons of sugar in a liter of water. And then we get back to all of the challenges with adherence. The taste is not very good. Most importantly, though, I would say is there is this kind of biomedical difference when you're comparing sugar salt solution to ORS. ORS has been shown to reduce the duration of diarrhea. It's been shown to reduce the severity of diarrhea, and it has been shown to reduce the stool output when compared to sugar salt solution. It is a different formulation, and so the consensus at the international level within the research community in this space is that ORS is what should be promoted. It is far more effective, and so that's kind of where we stand on that. But yes, this payment issue becomes a big question, right? And so the fact is that there will always be a segment of the population that likely won't be able to afford even that small, and I say small with a grain of salt, that small amount of money. And so there are a number of interventions that we've developed to facilitate access for that segment of the population through vouchers and other means. But I think the key point here is that when we look at it from a systems perspective, what we're trying to do is really increase access, right? So increase utilization and maximize the potential of the system to facilitate access. The fact is you can go to the public sector and you can get ORS and very rarely zinc at no cost. But there are a number of opportunity costs associated with that. And what we're really focusing on here is providing choice and providing opportunity. And so you're creating, when you're looking at it from a systems perspective, what we're doing is creating a complementary point of access. We're not creating a competitive point of access, we're creating a complementary point of access. And so it's not to compete with what the health sector or the public sector is doing, it's to say that if you happen to have residual income, if you happen to be able to afford that dollar and it makes sense for you to walk that 10 or 15 minutes to the local shop instead of taking that 3 or 4 hour journey to the health center, you now have that choice. So that's what I would say about that. Another point to make very clear, and the film doesn't necessarily do a great job at this, is that we make no money from this. Like we Cola Life, this is a purely academic and kind of development initiative. All of the money, and I know in the film it kind of looks, at one point you get that weird shot of Simon kind of holding that dollar bill and it looks a little bit shady. But Cola Life makes no money out of this thing. All of the money is staying in the local system. So we're building local capacity, local system, and there's this kind of economic aspect to this market-based initiative. And so what you have being done is jobs being created, money staying in the local system, and complementary points of access being created. And so what we've seen is that has resulted in increased coverage of this combination therapy. I think that's what I'll stop there for now.
Wonderful, thank you. I think we can turn it over to the audience if we have some questions from the floor. Have to be the person at the top of the stairs.
Hi, Rohit. It's Stu Taylor.
Hi, Stu.
IDE here in town.
Stu's a great friend of mine.
And I want to just make a comment, if I may, and then a question. And I think the comment also goes back to a moment in the film where Albert turns and says, "You're a diehard person." And knowing Rohit and Simon and Jane, I just want to make a comment to say, I think something that often gets lost in this is just the sheer shoe leather involved in creating this kind of success. The persistence, creativity, and just hard work and blind alleys that go into it, having tracked their work over a few years. Rohit, I know you're not going to toot your own horn in your presentation, but just to draw people's attention that it's a nice, tight presentation, but it's the result, there's a lot underneath the surface there of just sheer effort, hard work, trial and error. And so I just want to salute you and Simon and Jane for that.
Thank you.
Getting to the question and maybe continuing on in the vein of trying to kind of dive in and stir the pot a little bit. Working through the private sector brings its own challenges and its own risks in trying to create public goods. And so I'd be interested in your take on, as you were launching into this, what was one of your top concerns or the top risks that you saw in trying to move through the private sector to deliver this? And maybe if I could be permitted a somewhat double-barreled question. Along with that, what was one of the greatest challenges that you faced in approaching a private sector partner? Because obviously you're a little bit weird, a little bit odd coming. It's not something that Coca-Cola or SAB Miller or whoever would deal with every day. And then maybe you can just speak to one kind of aha or breakthrough that allowed you to deal with and or the challenge or risk that you saw and the challenge in approaching the private sector and getting them to kind of buy into this and deliver in a way that would be effective.
Sure, thank you, Stu. Stu, you should know, is part of an amazing, he's the CEO of an amazing organization called International Development Enterprises. And we share a lot of the same principles in our work, and really looking at entrepreneurs in the developing world, and creating social enterprises to not only advance economically but improve society in a number of ways. So thank you for that question, Stu. I guess I'll start with the challenge of approaching a multinational corporation like Coca-Cola. And it was a long road, and actually one that I kind of came in the middle of. I think there had been attempts to engage Coca-Cola prior to my involvement, and that was a difficult task. The conversations hadn't really progressed, weren't really progressing, and very much traction was hard to get. And really, I would say one of the turning points was this kind of open innovation approach that Simon and Jane kind of really started. It was, I was a senior health advisor at CEDA, at the Canadian International Development Agency, getting ready to start my doctorate, and I knew that this was a question that I wanted to answer. It had been discussed in public health circles for a number of years, but no one had actually looked at it from an academic perspective. And so I wrote, but the reason, when I started looking at the research, has anybody looked at anything like this? And no one had. But I did find this website on Facebook that this couple in the UK had started, and they were asking the same question. And so, the film shows, I kind of wrote to Simon, and that's how we got engaged. But it was through that open innovation approach and putting that question out on the internet that really started this whole movement towards engaging Coca-Cola, and really getting traction. I mean, the question was put up on Facebook, and that journey, the early thinking around how do we start to do this, how do we engage Coca-Cola, was put out through social media, and more people started following us on Facebook, and we started doing talks, and we started engaging, through universities. And eventually the BBC caught on to it. And they're actually, it's interesting because they're the ones who got us and Coca-Cola on one of their shows at the same time. And it was live on air that Coca-Cola actually agreed to partner with us and try out this social experiment. And so it was the pressure, I think, of being in a public, very transparent venue like the BBC, and I think that's really was a turning point. So I'd say this open innovation approach and sharing lessons and questions, and we've continued that process throughout our journey, through the website, through a blog. And that's been very, very effective, and engaged a number of new partners. Whenever we saw a gap, we would put a question out on through our blog, and we created partnerships through that avenue. So that's my answer for that. In terms of challenges and risks, I guess was the other question. So in terms of working with the private sector. Well, one is certainly, Coca-Cola comes in with a certain reputation, right? And it is this, and a lot of multinational companies come in with certain reputations in terms of their practices, and are they operating in ethical ways? And these are very important questions that we need to continue to ask, and that we need to continue to push these kinds of companies on. But I think it would be our loss, I think, if we didn't have the ability to at least explore the opportunities where we see potential for improvement. And we see that there are things to learn. You know, Gandhi always said, you can't shake hands with a clenched fist. And I agree with that. You know, I mean, that's my perspective. And I think, you know, we need to be open to collaborating across sectors. You know, I think in development in particular, you know, development 101, we start to learn that, you know, public sector good, private sector bad. And I think we need to, we're at a stage now in society where we need to kind of get beyond these old black and white kind of notions and recognize that there is this kind of gray area that we need to operate within. And there are opportunities there, not to say that you ignore those other things, because those are very important issues that need to continue to be addressed and pushed. So I'd say that is one of the challenges, especially with regard to some of the big corporate partnerships. And then I guess the last thing I would say is of course this affordability piece. So when you have the poor paying out of pocket, how does that jive? And I think the initial reaction, of course, is that, you know, that's not the right approach. But I think when we start to look at it in more depth, and when we speak with the poor, I think you hear a very different story. And I've had personal conversations with people, and I know that, you know, there is this desire to engage in markets. There is, you know, having a branded product does speak more to people in a lot of ways. Something that meets demand is there's a different value that's put in that kind of a product, as opposed to something that is free. You know, so the affordability piece is very important, and again, it comes back to this aspect of complementarity, right? So I think we need to be providing primary care for free. You know, I think that universal coverage of free healthcare is a very important goal within the public health community that we're working towards. But that said, I think that when we look at it from a systems perspective, there are you know, we have to look at the whole system and you know, create opportunities to maximize access and facilitate care and services. So I'll stop there.
Great, thanks. I think we've got another question here from the audience.
Thank you. Hi, my name is Zabine Kamisa. I am a PhD candidate in religious studies at University of Waterloo. So it's nice to meet you. My current dissertation research is on the intersection between religious diversity and social innovation and social entrepreneurship. So when you talk about design thinking, systems thinking, that just had you have a lot of buzzwords that remind me of my comprehensive exams. So with that in mind, I can see, you know, when you're talking about design thinking, systems thinking, it's often considered in production, implementation, ideation. You're thinking of every single thing and all the pieces that come together. The equivalent to understanding culture and identity might be intersectional identity, gender, race, class, religion. So I'm actually coming at this question, or coming to this conversation, more interested in the cultural experiences you may have had in terms of buy-in from the community. You mentioned the idea of, you know, the Coca-Cola being a cultural element that the community really understands. But also I noticed in the video things like the church, maybe language barriers, maybe who's involved in terms of providing medication to kids. Is it the women? There was the example from the video that mentioned the idea, the really, really commonly referenced example of, you know, women not being, the well being made too close to the community, so women can't talk about their cultural experiences because the walk is not that long. So that's a really common I guess, example that's used. I'm just getting to my notes here. So there a lot of students, you know, especially at our university, the idea of STEM having STEM programs having a direct impact on the public good, especially in Canada. I'm an advocate of STEAM, which is, you know, science, technology, engineering, arts, and math. So for you, as somebody who's in public health, how is cultural understanding, cultural diversity impacted your understanding of public health, and how you go about your research through qualitative investigation, and even experiencing the community firsthand?
It's a great question, and so important. You know, and I mean, we know if we look at the social determinants of health, we know that things like culture and religion are fundamental aspects of those social determinants. And I guess, you know, using the Cola Life example, we definitely saw this come up in a number of ways. One, you know, you referenced the Coca-Cola piece, and so I think one thing to state is that, you know, Coca-Cola in these communities, yes, it gets there, yes, it's always on the shelf, but the fact is that, you know, people aren't drinking Coca-Cola on that regular of a basis. And in fact, the kits ended up moving at a faster rate than Coca-Cola was moving out of the wholesalers. And Coca-Cola is something that is, there is this kind of cultural element to it, where it is something that is, you know, you drink when you're having a celebration, and you know, there's a particular, you know, event taking place, and so it's not something that's drank on a daily basis. It's something that is kind of, you know, a special occasion. It's like cracking a bottle of champagne. So that's just one thing about the Coca-Cola, kind of an observation. Language was very important, you know, and especially in Zambia. I mean, you have so many different dialects being spoken. You know, the language in Katete is different from the language in Kalomo. And so, you know, we had to think through that in designing the product. And so our instructions were in 2 different languages in addition to English. And then we had to take into account the fact that 30% of the adult population in some of those communities are not able to read. And so using images and graphics and really making sure that the graphics are clear, those kind of came into play. Colors were very strongly correlated very strongly correlated with certain cultural beliefs. So in rural Zambia, you know, Satanism is sometimes associated with the color red. You know, I had enumerators going into certain communities wearing a red bandana, and she was chased out of one of the communities. You know, so those kinds of considerations become very important. And so the human-centered design approach is really one that is meant to learn and take those factors into consideration and really get a good understanding of people's beliefs and people's perceptions, and how you can kind of work those lessons into the design of a product. And the last thing I would say is that you know, I think for any public health intervention, you know, we talk about external validity and how applicable is this in a different context. You know, this is the type of thing that, you know, the base model is probably has a high degree of external validity, but the specifics and the details around branding and how we take that forward, that would need to be adapted to every new context that we go into. If we try and implement this kind of a model in Nigeria or in Ghana or in India, that human-centered design process has to take place again. Because in every single one of those contexts, you're going to find different factors that come into play that will impact the acceptability of a product like this.
Great, thanks. We've got, I think, 2 more questions here.
Hi, my name is Annette Trimby. I'm the president here at University of Winnipeg. And in a past life, I was an ADM in a health and wellness department and a deputy in an advanced ed and technology department. And one of the things that I picked up tonight in the movie more so was almost the sense of, yes, there's a great need, but also there's an untapped market. And I know you were careful to explain that at the end of the day, this money all went back to the local economy. But I found when I met with large health pharmaceutical companies or other service providers, you know, this notion of reverse innovation to tap those markets. So the example I will give is in North America, if we get a crown, we pay a lot of money, but at 3M, they had developed this new type of amalgam that, you know, they could do a crown for $100 and it might last 15 years rather than 40 years, that sort of thing. So I'm wondering if you've got any thoughts on this need, this market, and what the private sector could do to reverse innovate some things that people in countries like ours, places in countries like ours are quite willing to pay for.
Absolutely. I think that's, you hit the nail on the head, and I think, you know, the concept of the North learning from the South, you know, is somewhat new, which is you know, unfortunate. You know, this concept of reverse innovation is so essential because there is innovation happening at the bottom of the pyramid, you know, and that's exactly what, you know, people like C.K. Prahlad have talked about, is that, you know, we need to co-create, and we need to tap into the bottom of the pyramid in order to create solutions that will address the needs of that population. And I think, you know, this concept of human-centered design, again, it really plays into that, and it's these bottom-up approaches that are the most successful. You know, I think with this Kityamoyo project, you know, it wasn't a matter of you know, let's partner with you know, the big multinational pharmaceutical companies. It was really about local capacity and building the local system, and so Pharmanova, you know, is a very small pharmaceutical company based in Lusaka, and you know, we chose to go that route for a number of reasons, and we had questions coming at us a lot of the time, which was, you know, why don't you partner with you know, one of the larger companies that can manufacture it at a cheaper cost? They can manufacture in bulk, and you can then import it. But there are so many benefits that we saw when we looked at, you know, the advantages of building the local system and building that local capacity, and keeping money in the local economy, and you know, reductions in delivery times and supply chain. You know, a lot of times with importation, you get stuck at the border, and, you know, all kinds of, there are a number of advantages that we saw with going with the local system and working with those small local partners. You know, so this project, when we talk about partnerships, the vast majority of the partnerships we developed were with small local organizations, community-based organizations, the private sector, you know, etc. Coca-Cola, even Coca-Cola, really, the partnership wasn't with Coca-Cola, it was with SAB Miller. So Coca-Cola, they actually have bottling companies throughout the world, and it's those bottling companies that actually operate in the local systems and have you know, relationships with wholesalers at the district level. And so the real partnership was actually with SAB Miller, facilitated by Coca-Cola. But then, you know, you go delve further into that, and you realize that, you know, Coca-Cola is not the only product that's getting to those rural communities. You have all kinds of fast-moving consumer goods that are getting there, and they're all using the same kinds of systems and same kinds of networks. And it's a matter of how do you tap into those networks and create demand for a product, make it profitable to fulfill that demand, and that's really what'll kind of move it through that chain.
Well, that's wonderful. You know, I think we're just about at 8 o'clock. We've had you sitting in front of your monitor, speaking to a screen, but knowing that there's a whole bunch of people here there's probably a lot more questions, and I can appreciate that, but I know that I'm aware of your time. I'd like to thank you.
Well, please email me. Please feel free to email, and I'm happy to answer questions.
Well, I'd like us to offer a round of applause. Hopefully you can hear it through your screen. It has truly been a pleasure moderating. I've not moderated a screen before, but you've made it a wonderful experience. You've shared a tremendous amount of knowledge and experience about innovation, about thinking outside the box. And for some of us here on campuses, including our student working on her doctoral degree, that academics do make an impact in our communities, and you can make change. So thank you so much for taking time. Thank you to everyone for making it out, and I know we've got some students here as part of the course, so I'm sure you have a busy week and it's been a long day. So again, thank you for coming out to the University of Winnipeg. Our wonderful guest is happy to take a few emails, hopefully in between delivery date and now. So thank you everyone, and good night.
Thank you. Thanks everybody very much. Thank you.